Inflammatory lymphoproliferative disorders. A review. Introduction. Inflammatory lymphoproliferative disorders, LPDs, represent a diverse group of conditions characterized by abnormal lymphocyte proliferation, often in response to chronic immune stimulation. They range from benign reactive conditions to malignant lymphomas. The differentiation between these entities is critical for management and prognosis. Classification: inflammatory LPDs can be broadly classified into 1. Benign reactive conditions, reactive lymphadenopathy, chronic inflammatory disorders, e.g. rheumatoid arthritis, Sjogren's syndrome. 2. Premalignant and borderline conditions, autoimmune-associated LPDs, post-transplant lymphoproliferative disorders, PTLD. 3. Malignant conditions, B-cell non-Hodgkin lymphoma, T-cell and NK cell lymphomas. Pathogenesis. The pathogenesis of inflammatory LPDs involves chronic antigenic stimulation, leading to 1. Prolonged immune activation, 2. Genetic mutations in lymphocytes, 3. Disruption of normal apoptosis and immune regulation. Key contributing factors include autoimmune diseases, e.g. systemic lupus erythematosus, chronic infections, e.g. Epstein-Barr virus, EBV, Helicobacter pylori, immunosuppression, e.g. post-transplant HIV. Clinical features: symptoms, fatigue, weight loss, fever, and night sweats, B symptoms in malignancy. Signs: lymphadenopathy, hepatosplenomegaly, and skin or mucosal lesions. Organ involvement: extranodal manifestations may occur, e.g. gastrointestinal tract, CNS. Diagnosis: 1. Laboratory tests, complete blood count and peripheral smear, autoimmune markers, e.g. ANA-RF, viral studies, e.g. EBV, HIV. 2. Imaging, CT and PET scans to evaluate lymphadenopathy and organ involvement. 3. Histopathology and immunohistochemistry. Lymph node biopsy is the gold standard. Flow cytometry to identify clonal populations. 4. Genetic studies. FISH and PCR for chromosomal abnormalities and clonality testing. Treatment. Treatment depends on the underlying cause and classification. 1. Reactive conditions. Address the underlying infection or inflammation. Use corticosteroids or immunosuppressants for autoimmune diseases. 2. Premalignant conditions. Monitor closely. Consider immunomodulatory therapy, e.g. IVIG, rituximab. 3. Malignant LPDs. Chemotherapy, e.g. CHOP for B-cell lymphomas. Targeted therapies, e.g. anti-CD20 monoclonal antibodies like rituximab. Hematopoietic stem cell transplantation in refractory cases. Prognosis. Prognosis varies based on the disorder. Reactive conditions often resolve with appropriate treatment. Premalignant and borderline LPDs require monitoring due to a risk of transformation. Malignant LPDs depend on the stage and response to therapy, with early diagnosis improving outcomes. Inflammatory lymphoproliferative disorders represent a spectrum of conditions with overlapping clinical features. A thorough understanding of their pathophysiology, diagnostic approach, and treatment options is essential for optimal patient management. Early recognition of high-risk patients can help prevent progression to malignancy. If you need further elaboration or specific references, feel free to ask. Similarities and differences between inflammatory lymphoproliferative disorders, LPDs, and systemic lupus erythematosus, SLE. 1. Autoimmune features. Both conditions involve immune dysregulation and chronic inflammation. Autoantibodies, e.g. ANA, may be present in some inflammatory LPDs, especially in autoimmune-associated types. 2. Organ involvement. Both can present with systemic manifestations, including lymphadenopathy, hepatosplenomegaly, and skin or mucosal lesions. Kidney involvement, e.g. lupus nephritis in SLE, and renal involvement in certain LPDs. 3. Immunological mechanisms. Chronic antigenic stimulation drives pathogenesis in both conditions. Cytokine dysregulation, such as increased IL-6 and TNF-α, is common in both. 4. Overlap in symptoms. Fatigue, weight loss, fever, and night sweats are seen in both. Raynaud's phenomenon and vasculitis may occur in autoimmune-associated LPDs and SLE. 5. Association with viral infections. Epstein-Barr virus, EBV, is implicated in both conditions, a potential trigger for LPDs and environmental factor linked to SLE. Differences. ASP inflammatory LPDs. Systemic lupus erythematosus, systemic trigger for LP to SLE. Pathogenesis. Chronic immune stimulation leading to lymphocyte proliferation and sometimes malignancy. autoimmune disease with widespread immune complex deposition and autoantibody production. Primary immune target, proliferation of lymphocytes, B cells, T cells, or NK cells. Loss of tolerance to nuclear antigens, e.g. DNA, histones. Clinical presentation, often presents with lymphadenopathy, hepatosplenomegaly, and constitutional symptoms. Multisystem involvement, including arthritis, rash, and serositis with hallmark malar rash. Autoantibodies may be present, e.g. in autoimmune-associated LPDs, always present, e.g. ANA, anti-dsDNA, anti-SEM. Risk of malignancy, significant, particularly for malignant LPDs like lymphoma, increased but less pronounced, e.g. non-Hodgkin lymphoma. Skin involvement, rare or nonspecific, e.g. nodules, plaques. Characteristic rashes, e.g. malar rash, discoid lupus. Treatment depends on classification. Immunosuppression for benign malignant therapies for lymphoma. Immunosuppressants, e.g. steroids, hydroxychloroquine, biologics. CNS involvement, rare in benign forms but can occur in malignant cases. Neuropsychiatric lupus, seizures, psychosis is a key feature. Key insights, shared pathways. Both conditions involve immune dysregulation with overlaps in cytokine activation and organ involvement. Differentiation. Diagnosis is aided by specific serologic markers in SLE, e.g. anti-dsDNA, and histopathologic findings in LPDs, e.g. lymph node biopsy. Therapeutic strategies. Immunomodulatory therapies are shared, but targeted treatments like rituximab are more prevalent in LPDs. Would you like further clarification on specific aspects? Diagnostic and therapeutic approach to inflammatory lymphoproliferative disorders, LPDs, and comparison with SLE. 1. Diagnostic approach. Inflammatory lymphoproliferative disorders, LPDs. Clinical presentation. Constitutional symptoms, fever, weight loss, night sweats. Persistent or generalized lymphadenopathy, splenomegaly, or extranodal masses. Features of immune dysregulation, e.g. autoimmunity, recurrent infections. Laboratory testing. 1. Complete blood count CBC may reveal anemia, thrombocytopenia, or leukocytosis. 2. Immunological testing. Autoantibodies, positive ANA or RF in autoimmune-associated LPDs. Viral studies, EBV, CMV, or HIV serology, especially in post-transplant LPDs. 3. Serum protein electrophoresis, SPP, to detect monoclonal gammopathy, e.g. in plasma cell dyscrasias. Imaging studies, CT or PET-CT for lymph node enlargement, organomegaly, or extranodal disease. MRI for CNS involvement in malignant forms. Histopathology, lymph node biopsy, gold standard for diagnosis. Reactive hyperplasia, benign conditions. Clonal proliferation, malignant LPDs. Flow cytometry, identifies clonal populations of BT or NK cells. Molecular studies, PCR FISH for clonality or chromosomal abnormalities. Systemic lupus erythematosus SLE, clinical presentation. Multisystem disease with characteristic features, malar rash, arthritis, nephritis, serositis, and CNS involvement. Constitutional symptoms, fatigue, fever, weight loss. Laboratory testing. 1. Autoantibodies, ANA highly sensitive, anti-dsDNA and anti-SEM specific for SLE. Antiphospholipid antibodies suggest antiphospholipid syndrome. 2. Complement levels, C3, C4, low during active disease. 3. CBC and urinalysis, anemia, thrombocytopenia, leukopenia, proteinuria and hematuria in lupus nephritis. Imaging studies, echocardiography, pericardial effusion or Libman-Sachs endocarditis. MRI, neuropsychiatric lupus. Biopsy, renal biopsy, essential for classifying lupus nephritis ISN-RPS classification. Skin biopsy, helpful for confirming discoid lupus. 2. Therapeutic approach. Inflammatory LPDs, 1. Benign reactive LPDs, treatment of underlying cause, antibiotics for infections, antiviral therapy, e.g. EBV, CMV reactivation, immunosuppression, corticosteroids for autoimmune-associated LPDs. 2. Premalignant and post-transplant LPDs, immunomodulation, reduction of immunosuppression in post-transplant cases, rituximab anti-CD20 for EBV-positive LPDs, antiviral prophylaxis for EBV reactivation. 3. Malignant LPDs, chemotherapy, CHOP, cyclophosphamide, doxorubicin, vincristine, prednisone for B-cell lymphomas. ICES, ifosfamide, carboplatin, etoposide for aggressive cases. Targeted therapy, rituximab for CD20-positive lymphomas, brentuximab vedotin for CD30-positive cases. Stem cell transplant, autologous or allogeneic for refractory disease. Systemic lupus erythematosus, SLE, one general management, lifestyle modifications, sun protection and smoking cessation, symptom control, NSAIDs for mild arthritis, hydroxychloroquine, first line for all patients. 2. Active disease, corticosteroids, low doses for mild disease, high doses for severe organ involvement, e.g., lupus nephritis, CNS lupus. Immunosuppressive agents, azathioprine, mycophenolate mofetil, or cyclophosphamide. Biologics, belimumab, approved for refractory lupus. Rituximab, used off-label for severe or refractory cases. 3. Lupus nephritis. Induction therapy, mycophenolate mofetil or cyclophosphamide. Maintenance therapy, azathioprine or mycophenolate mofetil. 4. Antiphospholipid syndrome, anticoagulation with warfarin or direct oral anticoagulants. 5. Neuropsychiatric lupus, high-dose steroids plus cyclophosphamide. Anticonvulsants or antipsychotics as needed. Key differences in therapeutic strategies: aspect inflammatory LPDs, suppress autoimmune damage, chemotherapy agents for malignancy. Goal of treatment: suppress lymphocyte proliferation, treat malignancy, suppress autoimmunity, prevent organ damage. Primary drugs: rituximab, chemotherapy agents for malignancy, hydroxychloroquine, corticosteroids, immunosuppressants. Biologics: brentuximab, rituximab for lymphoma, belimumab for refractory SLE. Role of infection management: crucial for reactive and post-transplant LPDs, important but secondary. Conclusion: diagnosing and managing inflammatory LPDs versus SLE involves a thorough understanding of their pathogenesis, clinical features, and overlapping mechanisms. While SLE therapy focuses on systemic autoimmune suppression, LPDs require a more targeted approach based on the nature, benign, premalignant, or malignant, of the lymphoproliferation. Early and accurate differentiation ensures better outcomes for both conditions. Would you like a more detailed focus on any specific aspect?